Hello, and thank you for joining today's webinar, Research into Action, How Immunization Research Influences Public Health Policy Decisions in Canada. This webinar is brought to you by the Canadian Public Health Association through the CANVax project, and in collaboration with the Canadian Association for Immunization Research, Evaluation, and Education, also known as CAIRE. I'm Antonella Pucci, CANVax Project Officer at CPHA, and I will be introducing this webinar. Before we begin, we want to acknowledge that the Canadian Public Health Association's office is situated on the ancestral and unceded territory of the Algonquin Anishinaabe people. They have been the guardians of this land for millennia, and we are grateful for the example their stewardship provides. CPHA is committed to working with all First Nations, Inuit, and Métis peoples and their governments in realizing meaningful truth and reconciliation. Next slide, please. So on to some housekeeping. The webinar is taking place on Zoom and all attendees are muted. If you have any questions regarding technical difficulties, please contact CANVax at cpha.ca and we'll reply to you as soon as we can. If multiple people are experiencing the same problem, we'll address it live via a broadcast message in the chat. As for the questions and answer session of this webinar, please submit your questions for the presenters in the Q&A box at any point during this webinar, and they will be answered at the end of this presentation. Next slide, please. Finally, here are some quick notes before we start. This webinar is being recorded and will be made available on CPHA's YouTube channel and on canvax.ca. Presentation slides will also be shared. We invite you to take a short 5-minute post-evaluation survey at the end of this presentation to provide your feedback in the delivery of this webinar. And finally, if you haven't already registered with CANVax or subscribed to our newsletter, visit canvax.ca today to do so. Next slide, please. Now I'd like to turn it over to today's moderator, Dr. Manish Sadarangani. Dr. Sadarangani is a director of the Vaccine Evaluation Center at the BC Children's Hospital Research Institute and an assistant professor in the Division of Infectious Diseases at UBC's Department of Pediatrics. He completed his undergraduate medical training and pediatric residency in Cambridge, Oxford, and London in the UK. He then completed his PhD with the Oxford Vaccine Group in the UK, developing novel vaccine candidates for protection against capsular group B meningococcal disease, and completed a fellowship in pediatric infectious diseases in Vancouver in 2013 before returning to Oxford to work as a pediatric infectious disease physician. He has also worked in pediatrics throughout the world, including sub-Saharan Africa, Asia, Australia, North America, and Europe. His research links clinical trials with basic microbiology, immunology, and epidemiology to address clinical relevant problems related to immunization and vaccine preventable diseases. Specific research interests include meningococcal disease and meningococcal vaccines, bacterial conjugate vaccines, understanding vaccine-induced immunity using systems biology approaches, meningitis and encephalitis, maternal immunization, and the microbiota and antibiotic resistance. So now I'd like to turn it over to our moderator.
Thanks, Antonella, and I would want to share my welcome to everyone for this joint CANVax and CAIRE session and two really exciting speakers to talk about research into action, how immunization research influences public health policy decisions in Canada. So next slide, please. So before we get into the speakers, I'll just first briefly mention a little bit about CAIRE. So CAIRE, as Antonella said, is the Canadian Association for Immunization Research, Evaluation and Education, which is a professional organization with a mission to enhance immunization research and program evaluation through education and collaboration among multidisciplinary experts in Canada and internationally. Next slide, please. So CAIRE membership gives people access to the whole network of professionals supporting vaccine research and immunization program development, evaluation and training, opportunities for funding and awards, supporting co-development of conference workshops, panels, and other educational opportunities, networking opportunities, including the CAIRE Research Symposium and members-only web resources. And you can find out more on our website, which is caire.ca. Thanks. Next slide, please. And I just briefly also want to give people a heads up about a couple of other upcoming seminars. one which is co-developed with CANVax on building community partnerships in immunization research, and another one on improving information about vaccination in pregnancy. And these are both in the next few weeks in June. Thanks. Next slide, please. So I'm going to introduce the two speakers today, and it's given me great pleasure to introduce both of them. So Dr. Deshayne is an associate professor in the School of Epidemiology and Public Health at the University of Ottawa and a scientist in the Children's Hospital of Eastern Ontario Research Institute. Her research focuses on safety and effectiveness of immunization during pregnancy using large linked databases and registries. From 2020 to 2022, Dr. Fell served as the NACI liaison for CAIRE and continues to operate as a member of some of the NACI working groups. Next slide, please. Dr. Frank is professor and now emeritus at the University of Toronto's Dalla Lana School of Public Health since 1983. Has also been the director of research of the Institute for Work and Health in Toronto from 1991 to 1997, and was the inaugural scientific director of the Canadian Institutes of Health Research Institute of Population and Public Health from 2000 to 2008. Between 2008 and 2018, he was the founding director of an Edinburgh-based unit funded by the Medical Research Council and the Scottish Chief Scientist Office, the Scottish Collaboration for Public Health Research and Policy. He's held a personal chair in public health research and policy in the Usher Institute at the University of Edinburgh, where he was also Director of Knowledge Exchange and Research Impact from 2017 to 2021, which time he retired and currently holds the post of Professorial Fellow. And the fact that he's here, you can see he's not quite fully retired just yet. I'm really excited to have these two incredible speakers for us today. Next slide, please. So with that, I'll hand it over to Dr. Fell. Thank you, Dr. Fell.
Thank you very much for the invitation to speak with you today. So my job is to set the stage by describing how immunization policy is made at a national level in Canada. Next slide, please. I don't have any conflicts to declare, and these are my disclosures. Next slide, please. So this is just a brief outline. So I wasn't sure exactly what the background would be of participants in the webinar today. So I'm going to start by just providing a general brief overview of what a National Immunization Technical Advisory Group is, or a NITAG, and then speak a bit more specifically about NACI's structure and scope. Provide a bit of information about the national immunization strategy in Canada and recent objectives that were set that have influenced the process that's used and the framework that's used for making vaccine policy nationally in Canada. And then finally, I'll speak a little bit about the process that's used to kind of drive the work of NACI. Next slide, please. So to begin with, National Immunization Technical Advisory Groups, or NITAGs, are in place in many countries around the world, including Canada. And according to the World Health Organization, NITAGs are multidisciplinary groups of national experts who are responsible for providing independent, evidence-informed advice to policymakers and program managers on issues related to immunization and vaccination programs. So they are an important component of a national immunization system, but it's important to note that they have an advisory role and not a direct role in implementation of an immunization program. Next slide, please. I wanted to also just distinguish, for those not familiar with NITAGs or with NACI, specifically here in Canada, the difference between the role that NACI plays as the NITAG for Canada, as well as the role of the regulator, which in Canada is Health Canada. So NITAGs work closely with the regulatory authorities, but independently from them. And the key distinctions between these two important groups at a national level include their stated purpose, which in the case of the regulator is to authorize specific products, vaccine products, or other products, and authorize the specific indications for use of those products, products, whereas the NITAG role is to recommend vaccination strategies really with a view of population health and control of infectious diseases at a population level. So the focus of the regulator is individual use of a product, whereas the focus of the NITAG is from a public programmatic perspective and population health lens. In terms of the type of data or evidence and research that is used by these two groups to inform their decision making, from a regulatory perspective, it's really the clinical trial data that are submitted by vaccine manufacturers that is considered by the regulators when they deliberate approving a new product. And of course, any post-marketing additional data that become available through things such as post-marketing pharmacovigilance surveillance programs. Whereas at a NITAG, for the NITAG, the evidence that is considered is much broader. So it's all relevant or available evidence that would include the clinical trial information for a new vaccine, but also any observational studies that are conducted once a vaccine is used in the population. And then also many other considerations, including public health considerations and so on. And we'll look in more depth at those in a few moments. Next slide, please. In terms of NACI's history, it was established by the Government of Canada in 1964, and again with a stated purpose to provide public health advice related to use of vaccines in the population. And this would include not only vaccines, but also some prophylactic agents that are also used. The WHO sets forth requirements and standards for NITAGs internationally, and NACI does meet all of the requirements laid out by the WHO with respect to their structure and performance and scope. So NACI really operates as an external expert advisory body to the government, in this case, the Public Health Agency of Canada. And the structure is shown in the figure on the right, in which there's a core group of NACI voting members. So these are the external experts in immunization. There are also a number of liaison experts, as Dr. Sadarangani referred to. I was the CAIRE liaison for 2 years, but there are a number of other organizations with liaison members, including the Canadian Pediatric Society, the Society for Obstetricians and Gynecologists of Canada, as well as other important key stakeholders. There are also ex officio members from various areas of federal, provincial, and territorial governments. And then finally, last but not least, the NACI Secretariat, which is comprised by FAC employees who basically do all of the work to gather evidence, synthesize evidence, and bring it to the core members for the purpose of generating new recommendations. Next slide, please. So NACI's scope has traditionally included making recommendations based on a framework that included considerations such as safety, efficacy, immunogenicity, and we'll look at these in a bit more depth in just a moment. But the mandate has evolved since 2016 to also include some programmatic factors as well. And again, we'll look at these in a bit more detail in a moment, but including things such as feasibility, cost effectiveness, and other factors as well. In terms of how it works in Canada, while NACI makes recommendations at a national level, provinces and territories do have discretion as to whether or not they accept NACI recommendations or perhaps modify them. Many jurisdictions do have complementary committees that often undertake similar types of analyses using similar frameworks and release their own recommendations as well, which may or may not completely align with NACI recommendations. Next slide, please. I'm not going to go into this in a lot of detail, but I wanted to touch on the National Immunization Strategy, which was established in 2003 by federal, provincial, and territorial ministers of health to provide a framework for encouraging and promoting interjurisdictional collaboration with regard to policy setting and recommendations for immunization programs across the country. So a number of objectives were set forth for the period of 2016 to 21, and I'm not going to read through each of these objectives, but you can see that several of them touch on themes of equity, access, and coverage of immunization programs. So in 2016, FAC announced that they would expand NACI's mandate to consider some additional programmatic factors within their recommendations. And again, we'll look at those in just a moment. And the intention of this expanded mandate was to provide additional federal leadership to better assist provinces and territories in making timely immunization program decisions toward equity across programs in Canada. Next slide, please. So again, I'm not going to go through all of this, but in the center of the slide, you can see, I don't think you can see my mouse. So in the red dotted box, you can see on the left, the NACI original mandate, which was really grounded on the scientific guidance that was provided with respect to how a vaccine should be used in Canada, and again, centered around core considerations such as safety, immunogenicity, and efficacy. And then the expanded mandate went on to include other factors that really relate more to programmatic guidance that provinces and territories could use in their jurisdictions. So this relates more to things such as cost effectiveness, acceptability, and so on. And this expansion of the mandate was followed extensive consultations across federal, provincial, and territorial levels. And really the goal here was to, as I said, improve equitability in terms of access to comprehensive guidance for decision-making around vaccine policy in Canada, to reduce some time lags between provinces and territories in their programmatic decisions and recommendations, and also to align NACI, their scope for NACI with other countries, NITAGs, which also have had a broader scope in place already by that point. Next slide, please. So let's look in a bit more detail now at the framework that's used. Next slide, please. And this shows what the framework was for NACI recommendations prior to 2019. So this is before the work of expanding the mandate was completed. So really between 2016 and 19, there were a number of changes, and we'll look at that on the next slide. But initially, the main considerations that underlied the recommendations by NACI included, of course, disease burden, which would include or encompass things such as the disease incidence, local epidemic conditions, risk factors for severe disease and illness, risk of exposure, and public health objectives. And then also vaccine characteristics, of course. So this would include the efficacy of a vaccine as well as effectiveness in the real world once it's being used in the population, safety profile of a vaccine, and also immunogenicity. Next slide, please. And this shows now the framework that's currently used since expanding the mandate and adopting these other considerations, which are more grounded around programmatic considerations. So these include the acceptability of a new vaccine program or an expanded immunization program, feasibility of the program given the existing resources within a particular setting, cost effectiveness of a program relative to other potential options, equity of the program with respect to accessibility of the vaccine for target populations, and the extent to which ethics have been adequately considered and addressed. Next slide, please. And this just more or less shows the same information. In the lower stacked bar, you can see the framework and the number of considerations that were in place between 1964 and about 2018. And then since 2019, the expanded recommendations or framework for recommendations has been adopted with the additional factors that I just mentioned. And then this slide also just shows that there are some additional considerations that are undertaken at a provincial and territorial level when decisions are being made around policy. Next slide, please. And just one other overarching principle that I wanted to mention, and I think hopefully this will set the stage for Dr. Frank's presentation, is evidence. So of course there are all these considerations within the framework for decision making at a national level, but there's also quite an intensive process that's used to grade the quality of evidence that underlies each of those specific considerations. And so many NITAGs around the world have adopted what's called an evidence to recommendation or evidence to decision framework. And I think it was probably the ACIP, which is the equivalent of NACI in the United States, that implemented this approach first back in 2010 when they adopted the grade approach for evaluating the quality of evidence, underlying recommendations. And then in 2018, further extended the grade assessment into a more comprehensive evidence to recommendation framework, which I won't get into. Many other NITAGs around the world and the WHO SAGE committee as well have since adopted similar frameworks, and this is the approach that is now used here in Canada by NACI as well. Next slide, please. So I'm just going to finish up with a brief summary of how the NACI work plan is driven. Next slide. In normal times, I guess, outside of COVID. Next slide, please. Yeah, thanks. So the NACI work plan really responds to FAC's information needs, and these are in turn triggered by programmatic needs that are identified at provincial and territorial levels, as well as clinician needs. Next slide. So with these immunization questions in mind, FAC then brings these forward to NACI. Next slide. Where there are a number of different working groups, probably about a dozen or so working groups within NACI. And so depending on the nature of the question, it would be distributed to the relevant working group where the question could be discussed, and potentially a very in-depth review of the question would be undertaken. Next slide. This then, after consideration at a working group level, would then be brought back to the central NACI committee. So the working group would provide advice to NACI. NACI would then feed that advice forward to FAC. And then ultimately, if the advice would lead to either a new recommendation, a new statement, or perhaps an update of a statement, then that product would be produced by NACI in the form of a NACI statement, which could then be shared with its primary audience, which are the provincial territorial immunization programs, and then also eventually in the Canadian Immunization Guide, which for whom the primary target audience is clinicians. Next slide. So that was my last slide, and I just wanted to acknowledge Dr. Matthew Tunis, who is the Executive Secretary of the NACI Secretariat, who provided most of the content of these slides. Thank you.
Thanks, Dr. Fell, for that slide. So I'll hand it over to Dr. Frank to talk about influencing public health and health system decision makers with research. Thanks, Dr. Frank.
Thank you, Manish, and thank you to all the organizers for the invitation to speak. I'm speaking to you from Edinburgh, where I've lived for 14 years and worked at the University of Edinburgh. This talk was developed over the last half decade as part of my role here at the University of Edinburgh to support faculty and graduate students in moving their research to action, which is a much shorter and I think easier to understand term than the other terms in this field, such as knowledge transfer, knowledge mobilization, knowledge exchange. But it's really the same idea, which is it's fine to do good research, but if it's never moved into action, obviously something's missing. And I'll just say parenthetically that the reason I really am involved in this is because I've been fortunate to have 3 directorships of startup applied research organizations since 1991 in both Canada and the UK. And I think basically I kind of learned the hard way about this. So next slide, please. So I'll cover a bit about the definition and the conceptual frameworks for that, which have developed fairly recently for trying to achieve knowledge to action in public health and health services or health systems research. I'll talk a bit about best practices to move your research into or move research into action. I know that some of the audience today are more likely to be the targets of such efforts by researchers and professional organizations would be those, for example, involved in delivering or program management. And those are often subject to efforts by researchers to influence their policies. And I'll give a few reflections and then finish with best practice for documenting research impact, which has been highly developed in the UK. Next slide. So in 2009, the MRC commissioned a landmark paper by Dr. Cooksey to provide a model for moving research into action. And it was exactly what was needed for laboratory research being moved into commercialization, largely through collaboration with the private sector. But that's not very helpful for moving research into not-for-profit action in the public sector. And I'll be talking about the latter because actually I don't have any expertise in moving research into commercialization, since I don't do lab research and don't hold any patents. So just next slide, I'll just show you some of, that's the paper that I'll be referring to, which was subsequent to this and some years. And it's by colleagues I know throughout the UK who sat on an advisory group to the Medical Research Council of the UK to develop a translational framework for public health research specifically. Next slide. That's as opposed to the Cooksey report some years earlier, which is really only relevant. Now, this is Cooksey's diagram. I won't go through it in detail, but you can easily see that it's moving from bench to bedside. It's about getting basic biological research on the left-hand side through to prototype discovery, preclinical development, early trials, and on the way through to actually making sure that whatever it is, a drug, a vaccine, a test, is produced at sufficient volume commercially to service a healthcare system. And the regulatory bodies at the bottom are in the UK. They're of no interest to you as Canadians, but there's a very elaborate system in most Western democracies for managing this process. It just isn't particularly relevant to moving research into public health and health systems action. Next slide. So what's different about public health and health systems research? Well, we're trying to improve societal level health outcomes, often through actions that are at the societal level, such as national or provincial territorial policies. And we're also constantly aware of the need to do so in a cost-effective way. But when we make those interventions happen, we typically require very diverse stakeholder support. Because if the action is taken by a Ministry of Health, or sometimes a completely unrelated ministry, say a housing action, tackling a major social determinant of health, then it will be just the health ministry involved. So we're used to dealing with very diverse stakeholders. The second thing that's special about this kind of research is that public health interventions can be based, well, I've said that, on sectors beyond health. Let's go to point 3, basic sciences that are involved, and there's a long list there. They are informative for the entire process, from the research done, which is often transdisciplinary in public health and health systems research, and makes extensive use of the social sciences and sometimes behavioral sciences. And therefore, our evidence for moving forward on the basis of research is often rather heterogeneous in terms of the methods, qualitative, quantitative, and therefore the quality criteria that we use to judge that evidence. So that means we have methods of synthesis which are broader than, for example, the standardized structured reviews of, say, randomized controlled trials for drug or vaccine regulation. And perhaps most importantly, public health policies, like all public policies across other sectors, are rarely determined by evidence alone. Many other factors matter: costs, who pays, who benefits, interest group politics, values, timing, public attitudes and beliefs. And we need to look no further than the recent COVID pandemic to see lots of examples of that. Next slide. So, in fact, research in public health and health systems knowledge to action is influences, but it's also influenced by culture, behavior, politics, and practice in many direct and indirect ways. It's not a linear translation as depicted in the Cooksey diagram for the conduit, the pipeline from basic science bench to bedside. Next slide. So this is an attempt by my colleagues in that 2009 paper about public health and health services research to depict the process. It's a bit busy. I'll just point out to you, next slide, that the basic science pathway is actually a little subset down here, in the sense that we do need to go from high quality research through to the development of interventions and then the completion of intervention studies. We do that in health systems and health services, but there are very diverse panoply of study designs and methodologies involved for that sequence, as I've said. And then we still have to do evidence synthesis, and then we move that into this much more complicated part of the diagram, which involves professional organizations such as the Canadian Public Health Association or advisory bodies such as NACI. And we're trying to influence health-related behavior of the population and in turn their health and well-being. But that feeds back by the process of public opinion formation. And so public opinion, of course, also influenced by media, culture, and what's gone before. So there's a complicated loop here. It's not linear at all. Next slide. So the evidence-based practice, sorry, just go back one slide. The evidence-based practice model is another subset within the Ogilvy et al. Model. And, you can see that perhaps the diagram's a little too busy to be really useful, so I won't belabor it. Next slide. So what are the implications? There's a few implications of this more complex conceptual framework for public health and health systems knowledge to action processes. The first is just doing a simple payback, a return on investment, which is typical of cost benefit or cost effectiveness analyses, is often not enough. You need to look at, for example, the distribution of benefits, costs, and risks. And there are methods available now for that, although they're difficult to make clear to lay audiences and the public. An example of this would be the importance in all health economic studies of time preference or social discounting, where a social discount rate typically chosen every year by the national treasury or of the country for different kinds of projects, there'll be a rate, say 3%. And that is the discounted value of all of the outcomes of any health or other sector program. So this means if you're preventing a disease, for example, by immunization, and a good example would be human papillomavirus vaccine given to preteens and teens to prevent carcinoma of the cervix. It is going to be the case that most of the cases of carcinoma of the cervix are 2, 3, or 4 decades, mostly the latter, far forward in time from giving the vaccine, where the costs of the vaccination program are incurred. And of course, if you think about what it means to discount those benefits by 3% per year, they come down to a very small fraction of their current, the current value is a very small fraction of their eventual cost or benefits value. So this means that you can kill prevention programs that are totally valid, but affect outcomes in the remote future. So that's the sort of approach which is very narrow. And I think one has to be a bit wiser than simply applying those methods in public health research, particularly if the outcome is going to involve virtual eradication of a condition in the population, for which, of course, so far we only have one really good example, and that's smallpox. But in the case of obesity, where nobody, I write scientific papers in this field, I have done for some years, no one believes we're going to treat people one at a time successfully for obesity. It's going to require societal change at a massive scale. So this means that in public health and health systems research, the process of moving research into action really needs to be embedded earlier than at the completion of the research and its publication. It needs to be started from the beginning, ideally, where the research users are involved with the researchers in planning the research so that it speaks to the research users' desk job, as it were, so that they will be able to place the findings of the research into context in their work. And it's framed in a way which speaks to the user's needs. And that is still hard to do. It's particularly hard to do in a granting system, which requires people to submit complete protocols for a process of research, which should ideally allow for interaction between the users and the researchers over a period of time. That period of pre-planning is often never paid for in standard research funding. And certainly I struggled at CIHR as the director of the Institute of Population and Public Health, first director, to try and get that in place, but it was impossible. Next slide. Another implication is that it's fairly onerous to do what I've just said, which is to involve the users in the earliest stages and make sure they're part of an active and not just a perfunctory advisory structure, an actual reference group for the research project. And so they not only get early results that are coming forward, but they hear about challenges in executing the research project, offer commentary, and are aware of the way in which the research project evolves if it needs to change from its original protocol, which is not uncommon, as those of you with the research experience knows. So in other words, that is a lot more engagement than many kinds of research expect. And of course, at the end, this is famously written up by Jonathan Lomas, an old friend who kind of founded this whole movement in Canada in the 1990s. You want to produce research projects for different audiences, 20, 30 page preprint of a published paper, 6 to 8 pages for policy analysts in a ministry, 2 or 3 pages for the chief of the policy unit, 1 page or less for the minister. And in the case of some ministers in some countries, you might want to make it a 1/4 page because they don't read anything longer than that. Next slide. So I'll just make a few personal reflections, observations I've made over the time I've been in this field. The first observation is policymakers often ask not just why should I care about this research, but why now? Why is that? Because for a given issue, policy windows of influence in time open and they close. And so a research project that wants to influence a particular policy has to think ahead of time about the timing issue. There's going to be a best time to present those results to decision makers, and there's going to be a worst time. A worst time would be when they've just made a decision, say in Parliament, about an issue, and you're coming along with evidence that challenges that. That's a very bad time to come forward, and you have to think hard about how you can mitigate those risks. Sometimes it means you have to report before you're fully ready. Of course, you have to caveat your presentation by saying our research isn't yet peer reviewed. Please be aware of that. But if you're pretty sure the results are solid and they're going to be of no interest to policymakers in, say, 6 months, you better get in there with them before your research is moot. And also, just remember that most policymakers who turn over pretty frequently are not on top of the historical research in a field. They don't know the literature like the researcher does. And it's important to summarize it in an accessible way for them. So never be afraid to present some old but relevant research if a policy window reopens. Institutional memories are short. Next slide. The second observation, and this is in the published literature about influencing policy and practice with research. Probably the most powerful researcher influences are indirect and informal. For example, by changing the way policy stakeholders think about an issue. So an example of this is that after I'd been here a few years, the Scottish government asked me on a very confidential basis to review a document they'd received from some health economists based in a major university here, in which they were proposing that it was necessary to do a major primary prevention trial in the community for ordinary risk Scots of cardiovascular prevention using very bog standard interventions like smoking cessation and dietary intervention, statins and so forth, but nothing novel about it. And although they had done a very detailed putative cost effectiveness calculation based upon some effect sizes they'd found in certain trials, they never thought of checking the Cochrane website for a structured review of all the trials. And so all I did was look up and found there were 55 trials and primary prevention of CVD, and that their relative risk reduction, if you summarize them, ones that could be put together in a meta-analysis, was about a 1% reduction in cardiovascular adverse outcomes. And indeed, the confidence intervals didn't even exclude no net benefit whatsoever. So it was a completely useless thing to run another trial in Scotland. There's no reason to do so. The problem is that over the long run, people don't comply with most of the interventions, and that's the challenge. It needs to be something much higher level than clinical one-on-one counseling around cardiovascular risk factors, as I'm sure many of you have learned in your own professional careers. So there's an example. What happened there was that I changed the policymakers' understanding of the processes. You don't go ahead and model what a good trial would show unless you've checked whether a trial is necessary. And the Cochrane review is often the best way to do that if it's recent and well done. So in your interactions with, if you're a researcher with policymakers, or if you're policymaker or program deliverer, in your interactions with researchers, it's important to mutually reinforce more scientific and critical ways of thinking, not just accepting a superficial version of the evidence. And this means certainly for researchers to take opportunities, any that come along, to provide broader advice that isn't just about your current research project. Policymakers get pretty tired of researchers peddling their own projects, and they always particularly feel tired of them being asked to open their purses and give more money to a given stream of research. So I think what you want to do is show yourself useful and try to provide continuing professional development, CPD, in an informal way whenever you're interacting with policymakers, so they get a larger picture of what, for example, the steps are in summarizing the evidence for or against the trial, as in my example of the importance of looking at the best structured reviews, systematic reviews first. And indeed, it's been pointed out that building the relationships between researchers and policymakers and program administrators is probably the most powerful way for the interaction to yield benefits for society. That means you need not to just be there when you're looking for a grant talking about your last project. Next slide. And this is an example that may not be very transparent, so I'll explain it. I was driving with my sister-in-law who lives outside of Ottawa in a fairly small town, Hope Town, and I saw this great sign, bake sale and antler display. And I want to ask those of you who consider yourselves to be familiar with rural Canadian life, why you would hold in one event both a bake sale and an antler display. Now, I'm not going to take questions on Zoom because it would slow us down. But of course, the answer is you want men to come as well as women so that you sell more baked goods, which is what's for sale. And in that part of Canadian society, geographically and socially speaking, the men are more interested in antlers from last year's hunt or several years' hunt than they are in the baked goods, although they'll eat the baked goods. So you have to hold a combined event. And that is a kind of example of how you want to achieve two purposes. Every time you interact, that is policymakers, decision makers, and researchers, try to capitalize in their interaction to make other points that may be helpful to the other party. Okay, let's move on. Next slide. And my last personal observation is sometimes stopping a bad policy, if you're asked to comment on it from a scientific point of view, speaking to researchers here, can be as useful as getting a good policy implemented. You'll be remembered for that because you'll typically save the public purse a lot of money. They were going to put £3 million into an unnecessary primary prevention, RCT, for cardiovascular prevention in Scotland only a decade ago, and I managed to point out to them that wouldn't prove a thing that wasn't already known. You know, a good example of something useless, a piece of useless research would be a study to try to improve men's uptake of prostate-specific antigen screening for prostate cancer. Why? Because we have very good controlled trials since the first one reported in 2009 showing that that type of screening does more harm than good. And you could read that trial by Schroeder et al. in NEJM in 2009. And I have taught with it for many years so that people understand that screening can do net harm. So I think for researchers, just remember, getting one more grant, especially to study a useless policy, is surely less important than keeping your integrity in the long run. And if you can document the downsides of a possible policy that's being considered, get that information to the decision makers, you'll be remembered in a positive light. Next slide, and I think we're coming to the end. For many years, the UK and I want to use the UK because it is one of the few countries, I've worked in 4 countries, but the UK is the one that has the most sophisticated way of rewarding universities for having research moved towards policy, practice, or commercialization. It's called the Research Excellence Framework, and it's just reported. The actual data was submitted by all the research universities in the UK, which would be a few hundred in 2021, but it's been now assessed by a very large network of independent peer review committees. And those peer reviewers have chosen the top ranked universities, not for the research and its citation index or other measure of so-called quality, but rather for its impact. How does it impact it on non-academic elements in society, including policies, programs, and practice? And they rank the universities, and then a lot of money is given out by the UK government according to the rankings. An example is that one of the key formats for submitting evidence on research impact in this REF exercise is the so-called impact case study. It's a highly structured, qualitative narrative with evidence brought to bear, such as triangulated information about what you did to influence a policy, and then some citation of how that policy was developed and your input as a researcher was, or your team's input was acknowledged. That sort of evidence, more like legal evidence than, say, epidemiological evidence. And that high quality, if it's deemed a high quality impact case study, just one can be worth £190,000 annually over the next 7 years after this REF reports this, just reported in 2022. So this incentivizes universities to take research impact and its achievements seriously. I don't think we have anything like that in Canada. I'd be happy to be corrected if something has developed since I've gone out of Canada. I think we could stand to have something like that, to be quite honest. Next slide. How do they define impact? Well, the REF uses a very broad definition: an effect on, change, or benefit to the activity, attitude, awareness, behavior, capacity, opportunity, performance, policy, practice, process, or understanding. It's a bit long-winded. It's pretty British. By an audience, beneficiary, community, constituent, and on we go. Beyond academia, in red font, I put that because it's not about what your research does for other researchers. For example, they say it's a great piece of research and it informed their research. That doesn't count. That's taken into consideration in a separate review process for each university, which is about how they rank in research quality. This is about impact, and it can be global. So I think it's worth looking at that if you're ever in a position to actually create an assessment of impact for your own, either your university or how research influences your practice or policy organization. Next slide. I've already made this point. It's useful to look at how the impact case studies are to be written. There's very detailed guidance about it. And then they're supposed to cite research in the gray literature showing that, say, practice guidelines, such as those of NICE in the UK for its NHS, or any other respectable set of practice guidelines, have made use of some research done, say, at a given university. And then you'd like to have testimonials by users of the research, ideally conducted by arm's length consultants. You can't send the researcher to ask a leading question: was my research useful to you, in the, say, interviewing Ministry of Health officials. So you want to allow for the possibility that the policymaker may say, well, I've never heard of that research, because if that's the case, it's suggestive that the impact was perhaps ideal. And finally, you want to collect this kind of archival documentation of influence on policy making. It's hard to find. And there are specialists now in British universities at finding this kind of evidence, tracking through a ministry website to see that a policy decision was influenced by a particular piece of research. And so it's a kind of case study for those of you familiar with that methodology. All right, next slide. I think we're at the very end. Well, a few caveats, a few challenges to documenting the impact for research. And that is, the timelines can be very long. Sometimes it's a decade or more between completing a piece of research and seeing it fully made use of. And that's particularly true for upstream determinants of health, where the policy process can be extremely slow. But I've already made the case so that HPV vaccination has a very delayed impact on the final clinical outcome, incident cervical cancer of an invasive sort. And so we've expected that, and we've accepted other serologic and other kinds of immunological evidence of efficacy in the interim. So when impacts are a long time off, it's pretty important to make sure that you've asked what stakeholders are expecting to be the impacts, so that when they start to accrue, you can look for them in a specific way. And the difficulty is that, of course, when you go back years later, nobody was involved in commissioning or even reading the research when it was fresh, and things have moved on. It's often a huge amount of turnover in policy organizations. So it's difficult, and it's better to have laid the groundwork ahead of time. But I admit that for projects in research that have long-term impacts, we're still terrible at documenting that impact. And chronic disease prevention is probably in that category. Policies to actually turn around the obesity pandemic will involve changes probably in the production, manufacture, and marketing of food, and maybe even the pricing. And we're not yet at the position that most countries are ready to take action, but I predict they will. Next slide, and I think we're at the very end, surely here. Oh yes, last point. If you're going to implement, as the UK universities do now, for senior researchers who have teams and they have large grants, they're supposed to influence policy, it's part of their mission, then you want to make sure that you reward the research team, all their members, for documenting any impact that happens. So for example, in annual performance reviews, they have a little section for research impact events, accomplishments that year, such as interactions with stakeholders, which might be an early stage in achieving impact, or actually some citation of the research done by the group in a policy process, say at the government level. And you want to have software which records that kind of impact in an easy to update way. I don't want you to think the British have done this brilliantly, because the UK, until recently at least, has used a piece of software called ResearchFish. If this ever comes around to your environment as a way of documenting research impact, please say that I said it's really badly designed. It has incredibly hard to use, overly detailed, and no readable printouts. So I think clearly they didn't get it to the beta version. But you can do this at least initially by asking all people in a research environment to have a section of their CV called evidence of research impact, if that's relevant to the field they're in. If they're pure researchers, they're publishing in Biometrica or a basic biochemistry journal, no, probably not relevant. Their impact is mostly going to be on other researchers, and that's fine. And I think that's the last slide, except a bibliography one. So next slide, we'll go there. Yes, so it turns out Canadians have written one of the best annotated bibliographies of knowledge utilization and exchange for public health and health systems research. It's one of the Oxford bibliographies in public health. There's the URL, you'll have these slides, but be aware there's a paywall. Your university or another institution you work for will probably be able to get you free access through an Oxford University Press subscription, but it is extremely well done. I'd like to particularly acknowledge my colleague at CIHR, my Associate Director, Erica Di Ruggiero, who spearheaded the writing of this report a few years ago. Thanks very much.
Thanks very much, Dr. Frank, for that very interesting and comprehensive overview, and for sharing all of your expertise and experience. So anyone who has questions, please put them into the Q&A. I can't see anything there right now. So maybe I'll start just, and you sort of alluded to this a little bit, Dr. Frank, if you could maybe specifically speak to the role of members of the public, patient advocacy groups, etc., in terms of that research process. And then, I don't know, Dr. Fell, if you could also, if there's been any discussion around more involvement with NACI, particularly with ACIP, there is opportunities for the public to address questions to the ACIP committee. So maybe Dr. Frank, if you want to comment on that first.
Well, patient and public involvement in all kinds of health research is now almost required in the UK if you have a grant from one of the funding councils. Certainly, you can't do clinical research without some sort of patient involvement. The trick is the group that you form or that you call together of so-called patient or public representatives, are they actually representative in any way? And I think that's much harder to be sure of. And sometimes, not surprisingly, you gather together people with a vested interest in one point of view or another. And in vaccination, I'll let Deshayne speak to that, because there's plenty of people with a very strong point of view, but it's not necessarily well-founded in facts. So, you know, it's tricky to have public and patient consultation advisory processes for research without falling victim to capture by special interest groups. Deshayne, you want to comment?
Well, I don't really have much to add, but I think it's a really interesting question. And I have watched some of the ACIP meetings where they do have the public, where they offer the public an opportunity to comment or ask questions, and it's pretty interesting. I personally haven't heard this discussed at NACI as something they're considering or might consider in the future. But of course, you know, the time period that I was there was just completely intense, dealing with all the COVID issues. So I'm not sure if that's been discussed at an earlier time point or since then. Yeah.
Thanks. So we have a question here from Alison. So how do we adjust research budgets to account for these changes? And her comment that it adds substantially to cost when it's done well, and it feels like CHR does not have the budget to deal with this. So I guess, Dr. Frank, given your role with CHR previously, maybe you want to comment on that, and then Deshayne, I'll let you comment on it as well if you want.
Well, lots of changes have happened at CHR since I finished my position in 2008. I was only there for the first 7.5 years, but I think one of the things that makes it easier to invest in co-production with research users and the public and patients, if relevant, is having some kind of a programmatic grant that lasts over a number of years and supports a team to work in a thematic area where the same stakeholders will be interested in the research. If you just have a little project grant, it is really impossible to use or to get the money and then use the money to do co-production, do the planning. And indeed, by the time you've written the protocol in great detail and got the grant, so many things are decided that it's a bit of a joke to claim you're going to do co-planning and co-production. So I think project by project grants are inherently difficult. And don't forget, they actually come from the basic science origins of CIHR when it was the old Medical Research Council of Canada prior to 2000. You know, in a lab, you don't have any reference groups typically. You're publishing findings that'll only be of interest and indeed only understandable typically to other scientists in the field. So in that era, fine, one project at a time, typically involving in vitro, in vivo, but not involving human subjects and not trying to change certainly practice in any immediate way. So I think it's clear to me that more and more programmatic grants, whether they're chair grants or training grants or grants to develop whole fields of research over a period of years, have been issued since I left CIHR. And I think that's a good thing. And within those grants, there should be some budgetary flexibility to allow for interactions with the potential users of research.
Deshayne, I don't know if you wanted to add anything from your own personal experiences.
Well, I mean, I guess what I would add is a reflection on COVID, and I'm not sure if any other researchers who are participating today feel the same way, but, you know, I think when I think back to grants that I had personally prior to COVID, you know, we typically build in a small budget for knowledge translation and involvement of or communication of our results to the public, scientific and general public. COVID has been quite a different experience, because what I've found with the research that I've been leading on vaccination during pregnancy, is that the need to communicate rapidly, but to many different levels, has been enormous. And I think we don't actually have, I could have used another whole person just simply to manage those communications, especially around, I mean, things were evolving so quickly, but also, as Dr. Frank said a moment ago, there are some really strong and polarizing opinions, of course, about vaccination, COVID vaccination, and vaccination in pregnancy, which has made it really challenging. And the need to disseminate clear information to the general public has been really crucial in this particular endeavor, and has been really time consuming and kind of difficult to manage around trying to keep the scientific work moving as well.
Thanks. And so I think we've got time for one last question. So from Elaine Powerfeed, Dr. Frank, so regarding research on the upstream social determinants of health, such as income, that it can be quite challenging to show impact because of the lag time, and it can take a long time. So in the UK, does that lack of ability to show impact affect the research projects that academics take up and that are funded, given your comments about the importance of the ref?
That's a tough question to answer, because we don't have the counterfactual. In other words, what we have is what the university rankings look like and the money that follows thereafter. And to be quite honest with you, I've not seen great evidence that the ref encourages upstream research on social determinants like income or education. And I don't think it's any deliberate discrimination against upstream research. I think it's the history of very short-term impacts being what's usually expected. For example, in drug or vaccine development, test development, treatment development. In those kinds of fields, you expect, if it's a successful initial trial or pre-trial studies, you expect it to come to some provable impact on patient care, typically within a half decade, certainly, unless it's a very delayed impact, like say cancer screening, where the impacts can often be more than a decade after you screen. That's trickier. But I think that we still have a dilemma. We have a problem. Universities are not, even in the UK, despite the ref, they're not really incentivized to do research for which the impacts will be both difficult and remote in time. I don't have an answer for that, but I think those of us who get involved in that kind of research need to be honest with ourselves that this won't be easy to demonstrate impact. One early indicator, a leading indicator, as they say, of impact is the opinion of policymakers that this research is going to be useful in the longer run. If you collect that at arm's length in a reliable way, I think that's a start. And I admit that's tricky, particularly if you do the research for a government of one political stripe, and then your research is reporting to a government of a different political stripe. So I'm not going to claim that always works out, but you should try and anticipate what policymakers, by documenting what policymakers are hoping this research may lead to.
Thanks. No, definitely difficult. I think any incentivization scheme is going to have holes in it, I guess. So I just want to wrap things up there. I want to thank you both for a very engaging and informative session and discussion. And thank you everyone for attending the webinar and for your questions. As a quick reminder, please don't forget to fill out the survey upon closing the webinar window on your device. And we look forward to the feedback so we can improve webinars for the future. So thank you everyone again, and hope you enjoy the rest of your day. Thanks.